Welcome back to Diabetic Files, the podcast where we speak wounds, tissue tells the truth, and science is storytelling. So today we're going to deep dive into another important topic, but overlooked, another villain of chronic wound healing, and is senescent fibroblasts. These are cells that may be one of the central reasons why diabetic foot ulcers stall, decay, inflame, and spiral towards amputation. So we're going to cover what fibroblasts normally do, what that cellular senescence actually is, how these fibroblasts become zombie cells, why diabetic wounds accumulate them, and more. So, the master builders of healing. Before we talk about senescent fibroblasts, we talk about normal fibroblasts, which we love. So, fibroblasts are the architects and the builders of tissue repair. When we have an injury, the fibroblasts migrate to the wound and begin rebuilding the damaged tissue. They produce collagen, which we want. They generate extracellular matrix. They support angiogenesis. They contract wounds. They communicate with the immune cells as well as stabilize the granulation tissue. Without fibroblasts, there is no scaffold for healing. So they are essentially the construction workers of our skin repair. So, as everybody knows, the normal healing process of wound healing is one, hemostasis, the platelet forms a clot, right? Inflammation, neutrophils and macrophages clean the debris. Proliferative phase, which is where the fibroblasts explode into action, and the remodeling phase, where the collagen reorganizes into stronger tissue. Fibroblasts dominates the proliferative phase, and they are responsible for building the new tissue. But in diabetic ulcers and wounds, something goes terribly wrong. So, what is cellular senescence? So, cellular senescence is biological state where the cells stop dividing permanently, but they refuse to die. So, they remain metabolically active but dysfunctional. So, think of it as they are biologically retired, they are permanently damaged, they are inflamed, and they are also toxic to the neighboring cells. And these cells enter survival mode instead of helping the tissue, they sabotage it. So, who discovered this? The discovery of senescence. So, cellular senescence was discovered in the 1960s, so recent, by this gentleman named Leonard Hayflick. Sorry if I pronounced it wrong. He discovered that normal human cells cannot divide forever, and fibroblasts had a finite number of divisions, and that became known as the Hayflick limit. I might as well. I'm down for it. And after repeated division, cells enter a non-dividing state. And at first, scientists thought these cells were harmless. But decades later, researchers realized something kind of terrifying about these. These senescent cells were actively producing inflammatory chemicals. They're not silent, they're not inactive, but they're actually biologically loud. Now, how do fibroblasts become senescent? Fibroblasts become senescent through repeated stress and damage. So, common triggers are hyperglycemia, oxidative stress, ischemia, infection, radiation, mitochondrial dysfunction, DNA damage, chronic inflammation, as well as advanced glycation end products. And in diabetic foot ulcers, all these occur simultaneously. So, the diabetic wound becomes a perfect storm for this accelerated cell aging. So, let's see the diabetic wound as an aging machine because the diabetic ulcer is not just a hole, it's accelerated aging environment because the hyperglycemia damages the protein, the microvascular disease causes ischemia, the neuropathy causes repetitive trauma, the inflammation becomes chronic, the bacteria forms its barriers with biofilm, the reactive oxygen species rise, and the wound essentially becomes a tissue war zone. And the fibroblast exposed to this constant stress finally says, I can't divide anymore. And they enter into the stage of senescence. So, senescent fibroblasts release something called SASP. I'm going to go SASP, 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 senescent associated secretory phenotype. Secretory phenotype. Yeah, sorry about that. So, this is one of the most destructive biological phenomena in chronic wounds. Senescence cells release IL-6, TNF alpha, IL-1 beta, matrix metalloproteinases, inflammatory cytokines, proteases, as well as reactive oxygen species. So instead of rebuilding tissue, they actually dissolve it. So these matrix metalloproteinases begin digesting extracellular matrix. The collagen gets degraded faster than it's produced. The growth factors decrease, and then healthy neighboring cells become damaged as well, right? Because you are the company you keep. So the wound enters this chronic inflammatory paralysis. So why do chronic wounds stall? A chronic wound often exists in a state where the inflammation persists. That's what we say most diabetic ulcers are stuck installed in that phase. The tissue breakdown exceeds the repair. The fibroblast stops proliferating, the angiogenesis declines, and the collagen synthesis fails. And this creates a wound that appears like it's frozen in time. Clinically, you would see pale granulation tissue, rolled in edges like an epibole, fibrotic tissue, persistent slough, delayed closure, recurrent breakdown. So the wound is alive, but it's biologically exhausted. So let's compare senescent fibroblasts versus normal fibroblasts. So healthy fibroblasts divide, migrate, synthesize collagen, contract wounds, and supports angiogenesis. Senescent fibroblasts stop dividing. They secrete these inflammatory mediators. They degrade the matrix. They resist apoptosis, and they impair the neighboring cells around it. So one builds, which is the normal one, and the other one corrodes. So why does diabetes accelerate senescence? So diabetes accelerates aging at a cellular level because one, the high glucose increases the oxidative stress, like we covered, the mitochondrial injury, the telomere shortening, as well as DNA instability. Telomeres are protective caps on chromosomes. So every cell division shortens them. Eventually, the cell senses danger and activates the senescence pathway. And the key pathway includes P53, P21, P16INK4A. I'm just going to call it PINK-A. But these molecules break. So once they're activated, the fibroblast permanently exits the cell cycle. So how do we test for high senescence? So there's no single perfect test for senescence of a cell, but researchers have a combination of biomarkers, histology, and molecular analysis. So like the one I call PINK4A, so it's called P16INK4A. So that's the most famous senescence marker. This is one of the strongest ones. This is a protein that acts like a cellular emergency brake. So when cells experience DNA damage, oxidative stress, telomere shortening, and hyperglycemia, they activate the P16INK4A to stop dividing permanently. So these high 16 expression strongly correlates with aging tissue, diabetic complications, chronic inflammation, and poor healing. And in research, tissue biopsies from chronic diabetic ulcers often show high elevated P16 positive fibroblasts. Another marker is P21. So P21, this also halts the cell cycle. So it's commonly activated by oxidative stress, mitochondrial stress, as well as DNA damage. So P21 is often an earlier stress marker than P16. Now, another one marker is SA beta GAL, okay? And it stands for senescence associated beta galactose. Okay, I'm so sorry. We're, that's it for that one. So, but this is classic laboratory test. The senescent cells accumulate lysosomal enzyme detectable under microscopy. So researchers stain the tissue blue to identify the senescent cells. But the problem is it requires tissue processing as well as biopsy and not practical for most clinics. Another one, like we said, is the SAP, the SASP cytokine testing. So remember, SAP, I'm going to call it SAP. SASP, so the senescence associated secretory phenotype. These senescent cells release the inflammatory molecules like IL-6, IL-1 beta, TNF alpha, MMPs, and researchers can measure these in wound fluids tissue samples as well as blood. So high inflammatory burden may indirectly suggest senescence. And then, like we said, the telomere length testing. So telomeres shorten as cells age, and researchers show that telomere length in wounds, they shorten. If it's shortened, it suggests cellular aging, chronic stress exposure, as well as replicative exhaustion. And then another DNA marker, DNA damage markers like gamma H2AX, as well as DNA damage profile, can show persistent genomic, genomic, yeah, injury associated with senescence. Sometimes I get tongue-tied. Everybody knows that. So, also RNA testing. So there are advanced labs that can analyze gene expression, senescence signatures, as well as inflammatory pathways. But the problem of this is where kind of where the future is heading. You know, one day wounds may receive a molecular age score, a senescence burden score, or a deterioration risk profile, kind of similar to cancer. So, guess who loves senescent wounds? Biofilm, right? Biofilm thrive in chronic inflammatory environments, and senescent wounds create exactly that. Okay, to give them what they want. So, because of that, this causes, and why is that? Because it causes their immune surveillance is weakened in these diabetic ulcers. The matrix becomes abnormal, the oxygen decreases, and the inflammatory mediators rise. So the biofilm then perpetuates more inflammation, which creates more senescent cells, and it becomes a vicious cycle. So it'll be like chronic inflammation, senescence, biofilm, and then more inflammation, and then the cycle continues. So they have this theory, the zombie cell theory. So scientists often call senescent cells zombie cells. Why is that? Because they are not dead, they are not functional, they're resistant to removal and harmful to surrounding tissue. They accumulate with age, but diabetes accelerates this accumulation dramatically. And a diabetic foot ulcer may biologically resemble tissues decades older than that patient's chronological age. So that means a 45-year-old patient may have a wound tissue behaving like a 90-year-old person's tissue. So, wound chronology and biological age. So, wound care is evolving, and the biological age of these wounds matters more than calendar age. Okay, so one may say the wound, or you have two wounds, and I've had the wound for 3 months, right? But one may have low senescent cells, active fibroblasts, and strong angiogenesis, and the other one may have severe senescent cells, mitochondrial collapse, and inflammatory exhaustion. So the chronological time of both of these wounds are different. So we would have to become more advanced when it comes to that. So how we already went about identifying markers. So how do we remove senescent cells? So there's something called senolytics, okay? Senoltics, senolytics. And these are therapies designed to selectively kill senescent cells. So instead of stimulating damaged tissue, they remove the dysfunctional cells entirely. So this is one of the hottest new fields in regenerative medicine. So potential senolytics include something called I'm gonna have to sound it out. Dasatinib. These are IV. I'm gonna just spell it. S. Oh, another one is quercetin and Feinstein, and then you know what? Lost cause when it comes to pronouncing these ones because these are new to my huge vocabulary right now. These are new to the vocabulary, but I'm just gonna spell them out. So Dasatinib. That's what I see in the research. And then we know quercetin, we know Finston, but this new drug is very interesting. But instead of forcing the dysfunctional cells to heal, they remove them, okay? Because senescent cells resist apoptosis, persist abnormality, poison the surrounding cells, and sustain the inflammation. So senolytics aim to clear these zombie cells. So I'm going to pronounce the different ones, the senolytics, But here's the thing, right? One is a leukemia medication, and it inhibits the tyrosine kinase involved in cell survival. So research discovered that it could selectively kill certain senescent cells, especially senescent fibroblasts as well as senescent adipocytes, the fat cells. But how does it work? It works by interfering with the survival signaling pathway, and senescent cells depend heavily on abnormal survival networks. So it cuts off their escape routes. And like I said, this one, the DASAD, that name. Yeah. You see that? Didn't do it. Forgive me. But I'm gonna pronounce it. D A I'm gonna spell it out, I mean. DASATINID. Oh, forgive me. Okay, alone is moderate, but they combined it with quercetin. Quercetin, they combined that, and that's a powerful combination, and that's actually one of the most studied combinations for senolytic medicine. So quercetin is natural flavonoid. So it's in onions, apples, berries, grapes, and it has an antioxidant, anti-inflammatory, as well as antifibrotic properties. In higher concentration, it can also act as a senolytic. Okay. And how does it help? Because it helps reduce oxidative stress, suppress inflammatory cytokines, inhibit senescent cell survival pathways, as well as to reduce fibrosis. Senescent. This is making me tongue tied in a whole different way. That's another flavonoid that is in strawberries, apples, I believe, and they find that is another promising natural senolytic. Because I'm just so stuck on that other one. But with Bicentin, oh, yeah, I pronounced it right, fine. Bicentin is exciting because animal studies have shown it can reduce senescent cell burden, improve lifespan, reduce inflammation, and improve tissue function. So some aging researchers believe Bicentin may be a broader senolytic for the effects to get rid of senescent cells. Now, when it comes to wound healing, okay, what are the features of that? Possibly senolytic wound dressing, anti-inflammatory scaffolds, and diabetic wound rejuvenation. So they're still experimental. And the last one is a very aggressive pharmacological senolytic. I'm going to call it navitoclax. Oh, there we go. Navitoclax. Okay, I'm just reading from the research page. Navitoclax is actually quite powerful because it inhibits BCL2 as well as BCLX1, and these are apoptotic proteins that help senescent cells survive. So, what makes that powerful? Because they have studied it, and it directly, actually, it pushes the senescent cell toward apoptosis. They're like, "You're done, go home. It's time to finish off and not be a cell anymore." So in studies, it efficiently clears senescent cells as well as senescent stem cells. I didn't know there would be senescent stem cells as well as senescent endothelial cells. But the problem is with that drug, okay, is it has significant side effects like thrombocytopenia as well as platelet reduction as well as toxicity concerns. But in short, could senolytics help diabetic ulcers? Potentially, yes. The theory is if you can reduce the senescent cell burden, you can decrease the inflammation, you can improve collagen balance, you can improve angiogenesis, you can improve the normal fibroblast functions, right? They can recover, and the biofilm susceptibility decreases. So theoretically, it can accelerate healing, reduce chronic cystity, as well as reduce amputation risk. So another question may be, are they gonna start treating and dress the wound like it's an aging wound, right? So the future of medicine needs to ask like how biologically old are these, and this can dramatically and radically transform limb salvage. So the future of wound care might include senescence mapping, wound aging scoring, things like that. Imagine wound care where we measure tissue age instead of just length, but you have to also think about debridement, okay? So debridement may partially work because it does remove senescent cells. It does help a lot removing those cells. But not just bacteria, not just necrosis, but Every sharp debridement resets the wound environment, which is why I love debridement, but you have to get vascular clearance. But this explains why regular debridement improves healing rates. I hope people get that, okay? So what are some of the clinical signs that you might have a senescent wound? So what suggests high senescence? A stalled healing, recurrent slough, chronic inflammation, fibrotic edges, pale granulation tissue, recurrent biofilm, poor graft uptake, delayed epithelialization. See, these wounds are stuck. That's why I love like even doing like a little hashtag and just waking it up. That even helps, honestly. So the philosophy of chronic wounds are that, they're challenging because the wound is not just static, it ages, it evolves, as well as it accumulates this biological memory. And these senescent fibroblasts may represent as scars of time itself. So the diabetic foot ulcer is not simply open tissue, it's tissue trapped in this prolonged biological stress. So some wounds fail because of pressure, some of our wounds fail because of ischemia, some of our wounds fail because of infection, but some of our wounds actually fail because the cells themselves are old and not ready to die and affect the other ones. So these senescent fibroblasts are changing the future of wound science, okay? Can help explain why some wounds are still stalling, inflammation persists, biofilm keeps on recurring, and why some ulcers biologically deteriorate faster than others. So the future of limb salvage may not only involve antibiotics, dressing, and surgery, but may include the ability to reverse cellular aging cells. So this is Diabetic Foot Files, where wounds speak, biology tells the truth. Forgive me for my mispronunciation. Every ulcer tells its story in written time. And I'm Dr. G, and take care of your feet because they take care of you.